It's my pleasure to now introduce the moderator for the last session in this room this afternoon, and that is my colleague, Dr. Monica Peak. Dr. Peak is a professor of medicine and an associate director of the MacLean Center. Monica, thanks for moderating this session.
All right. Thank you all for hanging in there with us and staying through the last session. I'm really thrilled to be able to moderate this last session today. The topic is something that I'm particularly interested in with my own research. I'm mortified to say that even though I broke bread with the first presenter last night and asked him how to pronounce his last name only moments ago, I've already forgotten. My apologies, Jacob. So our first speaker is Jacob Dahlke? Jacob Dahlke, who is a clinical ethicist and the director of the Office of Healthcare Ethics at Nebraska Medicine in Omaha. He's a graduate of the bioethics program at Union Graduate College, Mount Sinai School of Medicine, and he's currently a PhD candidate at UNMC. He studies the intersection of healthcare ethics, structural discrimination, and healthcare policy. He's contributed to medical ethics in Vermont and Colorado, and he's part of the first cohort of nationally credentialed bioethicists through the American Society of Bioethics and Humanities, ASBH. His primary interests in bioethics include advanced care planning, the intersection of systemic racism and bioethics, and healthcare professional wellness as it relates to moral distress and moral injury. Jacob.
Good afternoon. I would be remiss at the University of Chicago if I didn't invoke the patron saint of acquiescence, Franz Bibfeld. This is some of the work that I'm doing for my PhD dissertation, and so I welcome the opportunity to sort of propose this and pitch this to you and get feedback and hopefully lots of good criticism, because I definitely want to make this better. So here's my outline. Talk a little bit about the background, what brought us to be where we are today in healthcare, some of the issues that I see currently and some of the preliminary data that is justifying or motivating me to look at the future state, which is this project that I'm looking to embark on. So to begin, I think it's important to sort of, if we were to speak, if you'll allow me to speak corporate language, to level set here and establish where we are. Which is to say that structural racism and discrimination is deeply embedded across U.S. society, and with healthcare systems being a part of that larger society, it is, of course, assumed then that those smaller structures would represent the larger. This is also known at the regional and local level. The Douglas County Health Department in 2021 declared systemic racism as a public health crisis. To my knowledge, they have not yet lifted that, so we still exist in this crisis, right? And so we often attribute some of the underlying justifications and reasons for this as social drivers of health, social determinants of health. But we don't really, we attribute those as consequences, but not necessarily what are the actual structures that cause those social drivers in the first place. We could go back and forth as to what is the appropriate source for the definitions for all of these. I'm going to set that aside. I do only have 10 minutes here. So what I would say is I can provide a visual example. I have a bit of a bad habit of home remodel projects. And so I think of it in those terms. If we think of structural racism as everything down to the studs, right? It is deeply embedded in the structure itself. This concept of health disparity is the space within. The social drivers of health is the drywall, right? That's the stuff that we see. But while we recognize what those drivers are, it's often that's the studs behind it that are the ultimate cause. Health disparity is sort of the space that we live in, right? This is what we see. These are the gaps that we see in healthcare. This is the lack of access that we see. And health equity then is the roof, right? That's the aspiration. And I don't know if you've ever had to live in a space that doesn't have a roof or that has a leaky roof, but if we don't address that, everything rots underneath. And if I may be so blunt, I think that's where we're at right now. This is the portion of my talk where I get to stand on the shoulders of giants, and in this case, that giant is Dr. Jennifer James. She had, at ASBH in September, had probably, for me, the most thought-provoking and influential talk at ASBH in probably at least 5 years. I literally think about the things that she said every day since September. And so I don't need to spend time, I think, to this crowd especially, providing example after example of medical racism throughout our history, but it's there, right? And I think what Dr. James highlighted was this concept of using healthcare as she describes it as this carceral state, but really what I was interested in is how she attached at the end here this incentivization of compelling patients to acquiesce to care or to accept the care that we give. And if we don't, we penalize them, which in my opinion leads to this concept of noncompliance or in some cases non-adherence. So I've had a couple of conversations with people already yesterday and today about this concept of noncompliance, and I think another assumption I need to acknowledge is that I am considering these two terms to be the same. Technically, in terms of the linguistic definitions, they are different, but not by much, and perhaps more importantly for me, practically they are often used interchangeably, right? If we look at the sentence structure that we might find in someone's notes, if I were to switch out the friendlier term non-adherent with non-compliant, the readers of those notes, i.e. other clinicians, we still come to the same conclusions about how difficult this patient may be, right? So for me, practically, these are one and the same. And so for the purposes of the research, I treated them as one and the same. So about a year and a half ago, I did just a very, very small medical records review study that attempted to answer this question of do healthcare professionals describe patients as non-compliant at different rates according to the patient's race, right? It's a medical records review. Everything was anonymous. I didn't publish it. I haven't presented on it, but according to our own internal IRB, I didn't need to get their approval. This was background information. And so essentially what I did was I took 30 medical records, completely randomized for age and gender, from patients who in their medical records identified as Black or African American, compared it with 30 patients who in their medical records were identified as Caucasian or white, and essentially just went through the search function within Epic to find any records of some terms related to noncompliance and all of the word semantic or syntax variations, right? Whether it's hyphenated or not, whether it's a verb or adjective or anything like that. We searched for them all just to see what came up. And so what came up was really interesting. What you can see on the left here are the Black or African American patients, on the right are the white Caucasian patients. And so of those 30, we tried to find how often do we find compliance, and I use, again, that term generically. And the takeaway, the raw data is sort of meaningless because it was such a small number, but what we found was that there was a 2-to-1 higher incidence of describing or labeling Black patients as non-compliant compared to white patients. Additionally, of those patients that were described as non-compliant, Black patients were 8 times as likely to be labeled as such in multiple medical records. So it wasn't just a one-off, it just wasn't in one note from a physician or a clinician of some kind, but they're all repeated, independent notes, not just the copied pasted ones, but they're labeled and described as that multiple times. So my conclusion to that was, that's interesting, there's something there. So let's move this forward a little bit. So what I'm looking at doing for my research is to have a threefold component to this, three different components. And so first, I'd like to replicate the EHR review, make it a little bit more robust, much higher in, account for similar factors and try to equalize things out as much as possible so that we're only focusing on race. I also want to add in additional information about the clinicians themselves and what are some of the demographic information around them as well. For the second portion, I would like to recruit, and this is where, of course, I will need IRB approval, but I'd like to recruit as participants physicians and APPs. And I would randomize them to read through a vignette with a real basic questionnaire at the end in which we would ask them whether they think that based on the clinical scenario in the vignette, would you characterize this patient as being non-compliant or not? They would be randomized into one of two cohorts. The control group would be a vignette which includes no references to any sort of racial descriptions, and the variable would be that they have very similar vignettes, but that they do contain racial identifiers. And then finally, for the third portion of the research, again, I would be recruiting as participants physicians or APPs who would participate in the implicit attitudes test, which is out of Harvard University, very well validated, very robust survey that seeks to understand and describe what a person's implicit biases might be. And so essentially what it does is it concludes that based on how you responded within the survey, that you have a strong or weak preference towards or against a person being black or white as being good or bad, right? That sounds a lot more confusing than it is, but it's really enlightening actually. So essentially I would recruit people to participate in this and score them and again see where we are. So that's the overall research. I actually came in at 10 minutes, so we have plenty of time for questions and answers. I am not opposed if there's none. We can always end early. So thank you. Please.
I'm curious what your thoughts are about your vignettes. Have you begun to create them?
It's a great question. I have not yet created them. I mean, essentially, I'm guiding them towards seeking to answer that question around non-compliance. I would like to throw a couple of wrenches in there. Again, I'm not an expert in writing clinical scenarios, so that's where I'm going to be building my team out. But I would like to include some a situation in which the reasons for what we would characterize as being non-compliant are related to something like financial considerations. A person doesn't have access to daycare, or they don't have access to insurance, or they don't have access to transportation, which is why they're missing their appointments, which is why they're not getting their prescriptions refilled. So some real connections to these underlying causes to see where that goes. That's one. But thank you. Yeah.
Thanks. This is such interesting work. So I had a couple of thoughts based on a project I tried to do that was similar to this one. So one piece of advice I got was that sometimes vignettes, because it's just text, can really not bring out racial bias, even if it exists. Okay. So you might undercount if you use that approach. So, obviously using a video would be better, but sometimes people use animations, which are now pretty cheap.
That's a great idea.
So that might be one way of trying
Yeah.
to, at least elicit bias if it's there. The second is that increasingly, I think people are recognizing that there's lighter skinned versus darker skinned bias. Mm-hmm. So within racial bias is also really important to measure, and Project Implicit has an implicit bias test for that, as you may know.
Yeah.
So that might be something that would be helpful to include as well. And then the last thing is, I wonder if there are a bunch of people trying to measure ethics consults and racial bias within ethics consultation, and building, a database that includes a bunch of information across different medical centers. So it might be useful to talk to them and get access to that data.
Those are all useful tips. I appreciate that. One thing I will say, I am organizationally, we have started to. It's not a merger and acquisition, I promise you that. But our ethics department has begun to more formally work with our DEI department, under the basic premise that equity is ethics and ethics is equity. And you literally cannot have one without the other. I'm going to die on that hill, right? So why not work together on that? And so much so that we've restructured our ethics committee. It's now the Equity and Ethics Committee. So there are things there. So as a part of that combination of efforts, I'm collecting that data for my own consults of including demographic information. But it's useful to know that other people are doing the same.
Yeah, well, and it might just be a larger source. But it was one other sort of political comment, because it's on my mind as well. We have a combined research ethics and equity consultation service.
Great. And
one thing that we're anticipating is, what happens if there's this sort of target that focuses on equity efforts. So we are so far, we think it's really important to mark that we're addressing research ethics and equity.
Yeah.
But one thing and we don't want to change that in anticipation of anything, but I do think that there is this interesting question about, should we take research ethics and recognize the importance of equity within it to keep that from being a target at some point? Or, hopefully that day won't come, but that's something I've been thinking a lot about lately.
That's interesting. Thank you.
I was curious about the overlap between socioeconomically or economically disadvantaged and race, because I know as we've been collecting demographics, obviously we know that those populations, unfortunately, there's a great overlap, and that you were going to feature in your vignettes economic reasons almost seems too disclosive or leading in a weird sort of way.
Yeah.
I don't know, it's just a thought that I had. And then I also wondered about your chart review and looking at capacity of patients who refuse and when they're labeled as non-adherents. Did you do any kind of filtering out of patients who actually were delirious and refusing for that reason? Or, I don't know, just curious.
No, that is a good highlight, and I probably should have clarified that. These are clinic patients, so these are outpatients, and so there's the de facto assumption that patients have capacity unless they were to demonstrate otherwise. So I didn't actually address that. That's probably a limitation I'd have to acknowledge, because I'm not sure strategically how I might be able to capture that. But it's a good point, and at least a limitation acknowledgement.
Yeah, I also just wanted to mention we're looking at how to disabuse everyone of the concept of AMA for lots of reasons.
Thank you.
I don't even know where to start with that. If you have any ideas
I agree.
about that. I don't know if you saw Katie Watson's recent article published about labor and delivery. They did a study. It's ubiquitous, and I have made no inroads in trying to get our clinicians to change.
Yeah.
And even when you have some data.
Well, I'll play the villain and share my plan with you in front of everyone, which is to strike AMA and strike non-compliance and non-adherence from all medical literature and medical records from here to eternity. So
we'll do it.
I think we're on the same page there. Now I'm going to get caught, aren't I?
Thank you. To strip from the vignettes and kind of get at what you might be getting at in your project.
Yeah.
Do you feel like the events of environmental disasters that are people-made, i.e. man-made, like oil spills, results of radiated water, and the stew of respiratory illnesses that can come with being in a polluted environment like Cancer Alley, or the redlining of indigenous folks near heavily polluted dump sites?
Yeah.
Do you think that is an obligation that should be an obligation of care if we are actually acknowledging that racism, structural racism, has these not only poor health, mortal health outcomes?
Yeah.
That was pretty much it.
No, it's a great point. I mean, the short answer is yes. I think we do. I think for now...
I could tell how some care professionals will push back on that when they have to be responsible for caring for racism, but if they admit it and they are these gun hoers for DEI. And
Yeah.
unfortunately, at the commenter, I am from Utah University, and that is a tangible instance of DEI, EDI measures being
Yeah.
stripped
Yeah.
from institutions, and it is egregious.
Yeah.
If preventative measures are not paranoia.
Yeah.
I'll just say that.
Yeah. No, and I think actually Omaha is a great example of that. We have one of the most historically redlined districts in the Midwest region of putting people in that neighborhood and preventing them from leaving over the last 100 years. We haven't really done anything to correct that. It also isn't lost on me that we are also a major Superfund site and have incredible contaminants such as lead in soil that happens to overlap pretty decently with that particular neighborhood as well. So I think right now we're a very data-driven industry. I don't think that there's a lot of evidence that exists to demonstrate the direct causes here. If I want to change how my clinicians treat their patients, to your point, they need some local data. And like, this is my institution, right? This isn't a multi-site survey. This is us. And if we are doing this, then we have an obligation, to your point, to do this, to correct this.
Thank you. And then I'll wrap quick follow-up.
Yeah.
Would you say Cancer Alley is not a documented case of where environmental racism has taken flight and would kind of fill that gap you just suggested?
It could. I'd love to talk to you more about that offline. Yeah.
Hi.
Hi.
I was just curious what brought you to this topic. Like, what experiences brought you here? What connects you? What drives you to study this so intensely?
Partly we had, surprisingly or not, we had a new hire a couple of years ago within our organization who is our vice president for inclusion and diversity. She was the first hire within the organization ever 2 years ago, right? So just getting to know her and sharing the work, I saw, like, it was sort of the light bulb. This was around the summer of 2021 as well, right? So a lot was going on, and I was personally questioning a lot of what's my role here. And so I think a combination of what I was seeing elsewhere, but it was everywhere, and what I was seeing within my own organization, and just seeing the connections, and that's sort of when I arrived at my own conclusion of equity equals ethics, and conversely. And if that's the case, I'm trying to wrap my head around it, and maybe somebody wants to write it up with me someday, but I think we need to restructure how we think of our 4 principles, right? There's not 4 principles, there's one, and it's equity. And the others flow from that. And I don't know what that looks like. I'm a very visual person. I don't know if you know I talk with my hands a lot. But I want to explore that a little bit more, because that's where I see this.
Yeah, that's beautiful. Thank you so much.
Yeah. All right, thank you.
So I'm super excited about all of the conversation. I'm just sort of keeping an eye. I hate having to be the one who watches the clock, but that's my job. So thank you for your wonderful presentation and for all the excited commentary. Our next speaker is Christy Kirshner, and she is a clinical professor in the University of Illinois at Chicago's College of Medicine, UICOM, in their Department of Medical Education, DME, with a secondary appointment in the Department of Neurology and Rehabilitation and in academic internal medicine. She is currently the Director of Undergraduate Education for DME, and from 2015 to 2024, she was the Curricular Transformation Lead for Health and Humanities and Ethics, and their Ethics subtheme for the UICOM. Clinically, she's a physician who specializes in PM&R, so physical medicine and rehabilitation, with interests in the needs of patients with complex neurological disabilities, including adults with spina bifida, neuromuscular diseases, and cerebral palsy. Since 2019, she's been a member of the steering committee creating a lifespan disability clinic at UI Health, and she's a 1986 graduate of the University of Chicago's Pritzker School of Medicine and a fellow of our MacLean Center for Clinical Medical Ethics. She was the founding director for the Donnelly Family Disability Ethics Program at RIC, the Rehabilitation Institute of Chicago, serving in this role from 1995 to 2009, and was the inaugural special feature editor for ethics law for the Ethics Law column in PM&R, Journal of Injury, Function, and Rehabilitation. She's also an adjunct faculty member in the Department of Disabilities and Human Development at UIC, where she worked with Carol Gill, PhD, and Teresa Savage, also PhD and RN, to create the Certificate in Disability Ethics in 2003. So, Dr. Kirschner, thank you.
Thank you, Monica. It's great to be here with everyone today. This is one of the highlights of the year. So let me make sure I use this, right? Okay. So no disclosures. We're going to talk a little bit about disability bias. So I'm a disability doctor, and disability ethics has been the pond in which I've lived for much of my professional life. I do want to talk a little bit about where I think it comes from, why it results in harms, and I also want to leave us with some suggestions, both for ethicists and for healthcare professionals. So I'm going back to my ethics fellowship when I tell you this story. I was a fellow in 94, 95, and our wonderful case conference, weekly case conference, there was a case that was presented about a child who had disseminated meningococcemia. The child was facing a quadruple amputation, which is not uncommon with that condition. And the question that was brought to our case conference was, should we be continuing to provide intensive treatment and life support for this child who was going to be left with such an extensive disability? What would the quality of life be? And the discussion pivoted to a robust discussion of imagined quality of life. What would you want if it were you or your child? One of the ethics faculty members, and I'm going to preface this remark by saying this was in the day post House of God. A lot of dark humor was very, very common. But his comment was, he'll never do more than play second base, meaning that he would be second base. So that was a huge moment for me in my ethics fellowship, where I listened to the conversation and I thought, is that relevant? Is that the right question we should be asking? Are there other questions that we should be asking that we weren't? So there were no discussions about potential health outcomes or what it was like to live with this level of disability, what options were available for treatment, rehabilitation, technological solutions, and also what would be the role of the psychosocial environment, how the environment, social context, and attitudes would affect the quality of life for that child. So I began to think about, is this a heuristic, imagining ourselves, imagining our child, a useful heuristic? And what about even our own sense of what we think we would want? I knew a man at that time who was a quadruple amputee, John Kemp. He was born without limbs and became a very proficient prosthetic user. John became a civil rights lawyer. When I knew him, he was working at a high-powered law firm. He became the president of the United Cerebral Palsy. And that next week, actually, I brought in a video I had of John talking at a conference. But this is what people with quadruple amputations look like. This story about Charlie Gentry is a beautiful story if you want to look at a story of a young boy who was born without limbs, how he lived on a farm, he lived in a rural area, and they've got lots of video of him in his power wheelchair working on the farm. His mother going to his school and helping him talk to his kindergarten classmates about his disability. And these other two examples. So the examples are out there, and we can learn from people who have this. So if you actually talk to people and you looked at the data, you find that people with significant disabilities of all stripes, and disability is a very complicated construct because it involves a whole lot of different conditions, but you can find that you can have a significant disability and you can have a high quality of life. They're not mutually exclusive. And that health status and disability are distinct concepts. People with disabilities accomplish life tasks in ways many of us could never imagine. That the way people are treated has a profound impact on their quality of life. And one of the take-home messages is their identity is not reducible to one quality. If you ask them to describe themselves and who they are, sometimes disability is going to be 8 or 10 on their descriptors. So then, I think, okay, that was 30 years ago. Surely attitudes and knowledge about disability have changed since then. Well, no, not really. And in fact, what really strikes me is when you look at that IAT, which our prior speaker was referencing, there are 6 different forms of the IAT, and they looked at whether they were stable or whether they had changed over 2007 to 2020. And if you look at this is the implicit attitude part of the test. They had some marked improvements in certain ones, sexuality, race, skin tones, but if you look at disability, it's been pretty flat. We've not really seen improvement in negative attitudes towards people with disabilities. If you look at healthcare professionals, what do we see? Well, if you look at the implicit association test again, and you compare it to the explicit question, you can sort this into categories. The adversive ableist category is the category where people say, no, I'm not ableist, and then they indicate a very strong preference against people with disabilities. That is a higher number than the general population. We've got a problem in healthcare. We also have the wonderful Lisa Iazzoni study, where she surveyed health professionals about their knowledge and attitude about disability. It was a survey of 714 practicing physicians, and this was a remarkable study because they were asked explicitly, did they think people with disabilities, with significant disabilities, had worse quality of life than non-disabled people? 82.4 said yes. So there wasn't even a social awareness that this might not be a politically correct answer. People were just, they believed this. 40% actually were not confident that they could provide equitable quality of care. Only a little over half agreed that they would welcome patients into their practice. And about 20% strongly agreed that the healthcare system often treats people unfairly. In this same study, she queried them about their knowledge of their responsibilities to provide equitable care. What did they know about the Americans with Disabilities Act? More than a third said that really they don't know anything about their legal responsibilities. When they were queried specifically about who has to provide an accommodation, they got it wrong 70% of the time. A fifth of them didn't know who paid for the accommodations, and 2/3 felt that they were at risk for ADA lawsuits. So now the harms. So if we're ableist, well, what problems does that raise in the care of patients? COVID really exposed this. We had about half of COVID deaths that were tied to people in long-term care settings. And by definition, these are all people with disabilities. About a fifth of them were young people, less than 65, because we've had problems with institutionalization and keeping people in the home and community. We also saw that people were largely invisible. So if people did have a personal assistant that went from home to home, they did not have access to PPE. They were invisible in terms of getting their vaccines. So it took a lot of work and advocacy to try to elevate this. And then we've talked a little bit about categorical exclusions in the crisis standards of care. The first state iterations oftentimes included categorical exclusions of people with severe dementia, advanced and treatable neuromuscular disease, or people who required assistance with ADLs. And these were subsequently overturned by the Office of Civil Rights, that you can't have categorical exclusions. You have to focus on the individual and do individualized decision-making. But we continued to see harms during COVID. And if you haven't heard of the story of Michael Hickson, I've got links in the Washington Post and NPR. I would encourage you to look at them. Michael Hickson had an anoxic brain injury from a cardiopulmonary arrest. He's 45. He also had a partial spinal cord injury from the CPR. He had 5 children, a loving wife. This case was complicated because his wife had been removed as his guardian while there was a contested guardianship hearing, and a guardian ad litem had been appointed. When he became ill, and with COVID, there was a decision made by the healthcare team that he should have withdrawal of life-sustaining treatment and be moved to hospice because he had no quality of life with his disability. Very troubling story. And you can hear the words of the doctor talking to the wife that because of his brain injury and spinal cord injury, he had no quality of life. So this idea that this is, sort of common sense, that of course disability is a bad thing to have and it's going to result in poor quality of life. We hear the word ableism frequently now, discrimination of social prejudice against people with disabilities based upon the belief that typical abilities are superior. An ableist society is one that's built for people without disabilities, that you center people of typical abilities and you make people feel unwelcomed because the spaces don't acknowledge that they're going to be wheelchair users, people who need help getting on exam tables, who need to be weighed and can't step onto scales. So that's part of the structural ableism that we see. So I'm going to share with you now a personal reflection. In my college ethics class, which was in 1983, the first assignment that we were given was to consider a hot topic at that time in ethics. Should babies be treated with spina bifida? So about 1960, we developed the Holter valve, which was the breakthrough in the treatment of babies with spina bifida, because invariably, if you close the defect in the back, the child would get hydrocephalus. The Holter valve allowed us to put in a VP shunt if that were to happen. So babies were being treated once we had the Holter valve and the VP shunt. John Lorber was a neurosurgeon in England. He began to believe that we were doing great harm to society and to these children, that they were having lives of only great suffering, and that we should have selective treatment protocol. One of my colleagues and mentors that I worked with for years was Dr. David MacLean at Children's Memorial Hospital, pediatric neurosurgeon. And in 1973, he was the fellow. He took over the spina bifida clinic, and they strongly opposed that position. They said, we don't know that. So he developed a protocol where you treat essentially everyone, you study the outcomes, you publish every 5 years, and so that became sort of a warring position in the world of neurosurgery. So the question in my class was to read the positions and to, take my own position and argue for it. Now, there are nuances in the positions, and I can't remember all of the nuances that were presented to me at the time, but typically you would be asked, only treat babies with non-lethal lesions. If they had other cardiac problems, for instance, or if they had a high lesion, don't treat. Let nature take its course. What was happening at that time was babies were being put in the corner and not fed, or fed only on demand in many units. And in the Netherlands, of course, we've seen active euthanasia of babies with spina bifida. So my answer was treat only the best. I did not favor. I thought we were supporting these babies and that they would likely have very poor quality of life. Now I'm fast forwarding 20 years. I'm a physician. I take care of people with disabilities. I helped to start the Adult Spina Bifida Clinic at the Rehab Institute of Chicago. And one day, I was looking at my patients, and that memory of that paper came to me. And I was thinking, we have lots of data now on the quality of life of people with spina bifida. We've refined the protocols. We've got improved technologies. Society has changed. And I was horrified that my college self had decided that it was better not to treat people who were now my patients, because I thought that their lives would be very poor. The patients I cared for bore no resemblance to the people I imagined. And so, why did my college self so quickly adopt such a negative attitude? Well, I've come to realize we talk about hidden curriculum in healthcare. There's hidden curriculum in society. And we start encountering it from our very earliest days. We grow up in a society where there's still eugenic attitudes. We had a strong history of eugenics at one time. We have largely distanced ourselves from that, but there's a new eugenics movement that we're seeing. We have tropes and stereotypes that abound in movies and books, and this is just a few of them. But if you know $1 Million Baby or Me Before You, I'm going to call that one out, because tropes are storylines, and a lot of times disability is used as a plot device. If you were to look at those two movies, one won the Academy Award, the other was on the bestseller list for about 2 years, the trope is better dead than disabled. So the question is, well, is having a spinal cord injury for most people better off being dead than disabled? So we have to question these tropes. Most of these movies are written by people who are not disabled and don't involve people with disabilities in terms of acting. So a brilliant ethicist, philosopher Joe Strumando, and his wife Leah Smith, have talked about that a lot of ableism does rest in the medical model, that we're supposed to fix, to cure, to normalize the body, that there's something wrong with the person and we have to fix it. And Joe says, the simple idea is that disability isn't a tragedy but a difference, that people live very productive lives, they have health issues, they have challenges, but they also have the same kinds of wonderful things that make their life worth living, that most of us, we balance. We have all sorts of things that we're balancing when we think about a whole life. So I think that golden rule that I came to think about back in my fellowship self was, that's a really bad idea. We should not say, what would you want if that were yourself, for your child, that it leads us astray. If you have not experienced the condition or you have no familiarity with it, we're much more likely to have very negative attitudes. And the disability paradox literature will let you unpack that a bit, because it's true that we always underestimate the quality of life of people living with a variety of conditions. The Putnam Rule is probably a better one, where we think about making sure that people have access to high quality information, that they learn from those who live with the conditions. So some of the things I would say in terms of How can we as ethicists and health professionals do no harm? We have to do a better job with incorporating disability into our educational programs. It's a complex phenomena. Having a disability that you're born with is very, very different than having an acquired disability like a spinal cord injury. And you have to learn to parse that and think about where you are as a health professional coming into that person's life. We also have contact bias. We oftentimes are seeing people when they're having challenging events. We don't see them in the fullness of their life. Empathic curiosity and humility, they are the experts on their condition. We need their perspectives when we're making any kind of policy or protocol. They need to be there at the table and involved. We need more people in the health professions. We need to understand that when you're at the bedside of somebody who has a new onset disability, just like we talked about earlier today, that internalized racism happens, so does internalized ableism. And if you're standing there at the bedside and using very despairing language, your patient is going to internalize that. So the way we frame information becomes incredibly important. I've also come to believe that counter-narratives are really, really powerful. So me before you, well, let's look at other counter-narratives. Murderball. Has anybody in this room ever seen Murderball? Murderball is a documentary about wheelchair rugby. And it gives you an entirely different sense of what life is like with these men who are talking about sex and dating and all these things in their locker room. Crip Camp is another wonderful documentary, Being Human by Judy Heumann, who died last year. And then I've got a couple of examples of doctors with disabilities. And if you want to see a whole lot more, look at the Docs with Disabilities podcast. We have now, by the way, doctors with spina bifida, including Karen Marasco, who's the first female chair of neurosurgery, which in and of itself is a major issue. She also has a form of spina bifida. We have a spina bifida person who graduated from Loyola Medical School, who's now practicing as a pediatrician in Wisconsin. So I'm just leaving you with a couple of papers that we've been involved in terms of giving some tools and resources. This was a paper that was written with the Macy Foundation and the Hastings Center report of how we can begin to construct anti-ableist medical education. And then with my colleagues, Priya Tarsney, who's here somewhere, and Debjani Mukherjee, we wrote an article for the Hastings Center where we also put a lot of resources in there. So in closing, I'm just going to leave you with the fact that my patients, my colleagues with disabilities have been my greatest teachers. And I've lost 3 of them this year. Andres Gallegos was the head of the President's Council, the National Council on Disability. Diane Coleman, many of you may know her from Not Dead Yet. She's opposed physician-assisted suicide, medical aid in dying for years. She died last Friday. And Carol Gill, who was my colleague at University of Illinois. I think the most important thing is we should make no assumptions. That confidence that I remember hearing in my ethics case conference was misplaced. We really don't know about what life is like with disabilities. We have to hear the voices of people who live with it. You can never reduce a life to a single variable, and disability is complicated. Yes.
Thanks that it's me. Disability in the community and the clinical space is my passion, and thank you for your work. I love Joe, his work on the social model of disability and the medical model, and how that really informs our intuitions about this. And I just wanted to kind of add to what your presentation does. I recently did a presentation to genetic counselors who counsel often on adults who or families or individuals who are getting prenatal testing and what those testing results might suggest about their child getting a disability, having a disability, the outcomes or the probability. And the language that is used and has been collected and observed over time really informs the decision-making process. And this is not like a pro-life or insisting for a certain type of life. It's just about fair life, right? And that is something that I think is also missing, is how we talk about disability in the medical and clinical space, and how that is reflected of our own intuitions. And if you had just like some slight comments on that, like, you're where I want to be, and I offer my condolences to your dear colleagues and friends.
Thank you. Thank you. I worked in the Northwestern Genetic Counseling Program with my colleague Kelly Ormond, and we also worked with Carol Gill, and we wrote about that. How do you try to counsel people? We looked at health professional attitudes about cystic fibrosis and Down syndrome and spina bifida. So there is a little bit out there. Kelly is now in Switzerland. She's still working on these issues. And the other person is Tom Shakespeare. I think, again, we need to make sure that we're encouraging people to look at what it's like to live with these conditions, what resources and supports are available. A lot of times it's the tremendous fear of what their child is going to face, and we can provide high quality information, at least to help people make an informed decision. Thank you.
Right, we are 2 for 2 for amazing presentations. All right, our third presenter, actually, I have this out of order. No, I don't. Okay, we'll be talking about addressing discrimination and bias. Forgive me again for probably mispronouncing the last name. It's Dr. Kate Lundpray-Consit. She is a clinical associate professor of medicine in the Division of Hospital Medicine at Stanford, one of my alma maters. She is a perioperative specialist and cares for patients on the orthopedic, neurosurgery, and ENT services, while also practicing as a clinical ethicist. She's the associate director of clinical ethics at the Stanford Center for Biomedical Ethics, as well as the co-chair of Stanford Healthcare Ethics Committee and medical director of clinical ethics. Kate, welcome. And I'm so sorry to mispronounce that.
It's a long one. Okay, let's see. Good afternoon, everyone. Thank you for being here this afternoon. So I'll be talking about medical decision-making for unrepresented hospitalized patients and the transitions of care. As a practicing hospitalist and ethicist, I grapple with this issue quite frequently, as you can imagine. And so I'm really hoping to create a discussion about this topic, because I know that all of the hospital systems deal with this. My colleagues, Thad Pope, Brian Felder, we published on this, and so this is really an extension of some of those considerations. I have no disclosures. And so just a little bit of background in terms of, our unrepresented patients are among the most vulnerable patient populations in our healthcare system today. Unrepresented patients lack the capacity, as well as lack surrogates or any healthcare advance directive to guide in making medical decisions that are integral to their care. I haven't been able to find updated data on this, but the most recent data that I could find was in 2017. It was estimated that the group of unrepresented patients comprises of, at a minimum, 100,000 to upwards of over 300,000 patients, only with an expected increase as the baby boomer generation ages. As many of you know, state law and hospital policies exist for how medical decisions are made for our unrepresented patients during acute hospitalization. Ethics committees and providers represent the patient's interests while hospitalized. However, their ability to make these medical decisions remain very limited and are only valid during a hospitalization. So how do we solve for this problem? Well, guardianships or probate conservatorships have traditionally been the judiciary route that ensured that our unrepresented patients are medically cared for, not only on an inpatient but also outpatient setting. The problem is that medical guardianships take a long time. It's resource intensive, and oftentimes the conservator knows very little about the patient that they are representing. My biggest concern is who actually makes medical decisions for these unrepresented patients while awaiting the completion of the conservatorship process. The spectrum of decision-making for this patient population upon transitioning out of the hospital is dependent on state-specific guidance, but there's variability in that practice and potentially a gap in care. Decisions can fall onto providers, medical directors, or subcommittees of facilities, caregivers, and even worse, no one at all. Our unrepresented patients are at high risk for overtreatment, for fear of litigation, undertreatment, because they are lost to follow-up, they miss appointments, procedures get delayed, because no one's making decisions on their behalf. And this really impacts their overall morbidity and mortality. We know these cases all too well, and this just further highlights how vulnerable this patient population is. And so now I'd actually like to talk a little bit about when it actually does and can go well, and how we as clinicians and ethicists can be the ongoing advocates through the lens of increased awareness, thoughtfulness, advocacy, and very deliberate decision-making when we talk about our hospitalized patients, both from a clinical team's perspective, but also from an organizational perspective. So with anything, case presentation, 78-year-old female, extensive metastatic breast cancer because she was lost to follow-up before. History of pathologic fracture, she got that fixed. She's now coming back to our hospital for progression of her disease. She had multiple vertebral fractures, new pathologic fractures in the iliac bone, extensive mets to the sacrum, so quite sick in a way. The patient lacks capacity in surrogates, and conservatorship had been initiated. The only thing we knew about her when talking to her is her expressed values of wanting to walk again and not being in pain. The surgeon was unwilling to do surgery if chemo and radiation were no longer options for the patient. And so the surgeon was having a really difficult time grappling with, what do I do in this situation? Of course, ethics was consulted, and we convened an interdisciplinary discussion with the inpatient, outpatient oncology attendings, as well as this orthopedic oncology attending. And what was discussed during that case conference was, yes, her disease had progressed, but there was actually several more lines of therapy that could be administered in the outpatient setting. Some really good oral options that are well tolerated, minimal side effects, and if the patient were compliant, the likelihood of her being compliant was vastly increased because she was going to go to a skilled nursing facility. It would actually control her symptoms and her disease state for at least 6 months plus. So some highlights to this particular case was that the ethics team was actually able to convey some of these known values, not only on the inpatient side because it affected surgery, but also to the outpatient teams who are actually caring for her. And in collaboration with the two teams, we're able to agree upon next steps in terms of risk, benefits, and really aligning it with what we know of the patient over several admissions. It's important to consider, this case taught me, it's important to consider how medical decisions are made for our unrepresented patients because inpatient, outpatient decisions are invariably intertwined, each influencing the feasibility and implementation of that clinical plan. We could spend $500,000 trying to care for someone in the inpatient setting, but if there is no help and coordination in the outpatient setting, our care would have been for naught. And so this really heightened my awareness and the need for collaboration, communication, and coordination of care being key factors to optimal patient outcomes, even more so in our unrepresented patient population. the surgeon was about to not even offer surgery because she purely just didn't have a decision maker. The second case I wanted to highlight is of a 72-year-old female, severe non-ischemic heart disease. Her ejection fraction was about 17%. She had bad valvular disease, hypertension, delusions, maybe psychosis versus neurocognitive disorder. She had recurrent hospitalizations for heart failure exacerbations, now coming in for the same in the setting of noncompliance. We'll have to talk later. The patient, of course, lacks capacity and surrogates. What was found out was that she takes some medications, but not all. The team voiced their frustration on what can we actually do for this patient. She keeps coming in, we tune her up, she leaves, and then she doesn't take her medications. This sort of futile cycle would lead to nowhere. And so they were actually, and surprisingly, recommending comfort-focused care. And so they wanted ethics to weigh in on that. So I asked, what would the best case scenario really be if she consistently took her medications? They said she would be considered medically optimized and it could extend her life years, improve her quality of life. They incidentally got a repeat echocardiogram, and the EF was actually 23%, showing evidence that her EF actually did improve with taking some medication. So she wasn't necessarily end stage, so comfort care may have not actually been the most appropriate. So some other learning points from this particular case is identifying barriers for what med noncompliance, and could we optimize that? The cornerstone of this particular case was that clear communication with the accepting facility was going to be key in terms of the med compliance concerns and what to do if the patient refuses, because I don't think anybody wanted to force these medications, but how do we work with our patient who lacks capacity and surrogates to do so? So for example, coming up with a plan, if you give Lasix at 9, she refuses it, offer it again. You know, really simple, easy things. Or if she doesn't take her Lasix that whole day, well, give an extra dose the next day if she's willing to take it. And so really having this detailed plan of ifs and thens for continued medical management in the outpatient setting can really help improve our patients' care. It may be dynamic and it may be a little bit out of the box because usually orders to skilled nursing facilities are very sort of strict and they're just implementing those orders. But the resolution in this case served as a way for the patient to have an improved quality of life, increasing in number of years of life and decreasing the frequency of hospitalizations for med noncompliance. And it really was not really a patient problem per se, it was more of a systems problem. And how could we actually do better as clinicians and ethicists to ensure that that transition from an inpatient to outpatient setting was a lot tighter? And so in conclusion, we know our unrepresented patients are vulnerable, and this is only going to get worse as the years go on. Conservatorships are the judiciary route for having someone oversee this patient's medical decisions and care, but there is a gap. There's variability in practice by state. And I would argue that because of this variability in state laws, we as clinicians and ethicists have to deal with this at an institutional level. And so my question to you is, how can ethics and the care teams continue to advocate for our unrepresented patients? Our professional and institutional obligations, in my opinion, is to ensure a smooth transition of care even after they leave the hospital. They're still our patient, whether they're in the hospital walls or not. And so just some of the, based on the cases, illustrated just some opportunities for us to ensure that transition of care notation in the chart to say that this is how ethics made decisions for this patient. Because if they really are pending conservatorship, could that actually help inform the conservator who may not know anything about them, while we've already done this huge search and evaluation and due diligence to find out who this person was? The coordination of care is so important, and engaging providers early on from the outpatient to inpatient setting. And then also handoffs, right? The handoffs as a hospitalist, it's all about handoffs. And so an actual MD to MD handoff with these vulnerable patient cases, and setting up a plan with contingencies so that we can minimize, the disruption of care and the delay of care. And so what I'm ultimately proposing here is identifying these barriers and beefing up our workflow and streamlining how do we actually care for patients on an inpatient setting and transitioning them to an outpatient setting while awaiting conservatorship. I'd love to continue to take care of these patients even when they're not in the hospital. Thank you.
Thank you for your presentation. I know that you ended asking, what should ethicists do? And one thing that I noticed is it seemed like the assumed course of action that would be that these patients are transitioning to a skilled nursing facility. And I was just curious to what extent you think clinical ethicists and care teams should be informed about home and community-based services to really push to have people in the community as much as possible with appropriate supports, and how that's balanced with concerns over medication use or compliance as it's framed here.
Yeah, no, thank you. I think that if every state had that, I think it would be extremely helpful. In California, we have the EPIL bill that really puts the onus on the skilled nursing facilities to create an interdisciplinary team to get a patient representative and make these decisions for them. But other states may not have that mechanism. And so really the community resources are going to be the most important things to help support these patients. And I don't think that we know enough about them. Part of our DEI and community efforts at Stanford is to really understand what the community resources are for some of our vulnerable patients. And so that is definitely ongoing in how we can coordinate some of those transitions of care as well as resources.
Thank you so much for this work. I am a primary care provider, and I'm also a SNFist. And so our poor fellows have heard me say this a million times, so I'm so sorry. But I think I like your earlier point, bringing in the outpatient team. I think as an ethics team, we can take a step back. The hospital teams are not alone in this. There are people in the outpatient world for folks that know them, have maybe heard something in a clinic visit. And I think, I'm curious your thoughts on how we can break down these silos a bit, and the amount of effort that a lot of PCPs go through to be involved in their patient's care. Now, this is different, right? Unrepresented,
Yeah.
but still, I mean, the amount of effort, it's just opt-in rather than opt-out, being contacted. Do you have time to engage? And I think my other question would be, how can we really promote this MD to MD transition to SNFs? I mean, I'm lucky if I get a discharge summary. I'm lucky if I get a correct med rec.
Yep.
If a med is important, our offsite pharmacy will take a day, maybe 2 days to get it. So I think, how can we really stress as ethicists and as our committees, stress how important it is to form this collaboration? So thank you so much for this.
Yeah, no, thank you. Thank you for the work that you do too. I think, in terms of, as part of the ethics consult, anytime they call me for a patient who lacks capacity in surrogates, I always say, did you talk to their primary care doctor? Because our primary care doctors are awesome. They know a whole lot more than we do because we only see these patients at one point in time. So getting collateral is so important. And so that's something that we definitely encourage very much so. And to the point of when we actually could not find any surrogates, we had the primary care doctor communicate values, and then the ethics committee was able to make a recommendation based off of what is actually known. of that patient. And so I think really creating some kind of network to be able to engage our primary care doctors in that way and vice versa is so important. And the second thing is, I'm trying to remember your second question. How do we get providers to get involved earlier as ethicists? So honestly, I think it should be part of every ethics consultation, because any decisions we make today is going to affect tomorrow. And it may be in the hospital, but it may not be. And so my hope is to create workflows and streamline things to the point where it's so easy for people to do this, and it's just an automatic thought. My fear is that I don't think our residents and fellows and maybe even attendings understand how vulnerable unrepresented patients really are, and how much you really do need to go a whole lot higher in terms of your transitions of care to ensure, because I think they think they'll just be taken care of, discharge, done.
Thank you so much. I just wanted to say that I think a lot of inpatient docs and social workers don't know a lot about resources with waiver programs. So if you're in a Medicaid waiver, you can get personal assisted services with PACE programs, which oftentimes are Medicare and Medicaid. You can get wraparound, visiting nurses and doctors in the home. Because I think that a lot of times, when we're wanting to discharge somebody, the SNF is the most timely option. But if we could start the process, see them back, and try to make sure that we get them back into the community if possible. And sometimes the rehab stay, right, can help with that. So I think knowing about all these options for home and community-based services, the Department of Aging in many places can also offer help. So thank you.
Yeah, no, absolutely. Thank you so much.
Thank you for all the work that you're doing. Part of me feels that, yes, I want patients to be able to, getting the care they need, making sure that they have somebody that is speaking for them if they're not able to truly speak for themselves. But I also feel that it's going to be overextended, right? We're living in a society where people are living longer because we have the ability to do more things for them, which is amazing. But then if every unhoused, unfriended person has a conservator person, we're going to run out of conservators. And so I just feel that just trying to figure out if there's another option, if there's more community involvement, more people, more providers, other sources that can help these patients, because I just don't want us to run out of our current resource. I'm palliative, I deal strictly with inpatients, but every single time a patient's gonna, we just get a conservator. We just get call the state, get somebody to speak for them. But I just feel that it's gonna eventually we're gonna run out of people, because there's just so many people need so many resources, and so many people only have themselves to depend on. So I just I guess it's not really a question, just more of a comment.
No, it's so true, because our conservatorship process is just so overwhelmed and so inefficient, but really thinking more upstream to how do we sort of conserve some of those resources I think Thad Pope had written about this, that we got to make sure, do they really lack capacity? Are they going to continue to lack capacity, or can we reestablish it? Did we do a due diligence search for surrogates? Because sometimes you really can find someone 100 days out from hospitalization. And so all those sort of easy things to do to ensure that is there really anybody or not? And really conservatorship should be the last resort, but oftentimes it's not, and people just jump to that right away because it seems like I've done something, check, and moving on. Thank you, guys.
Okay, we have our last speaker of our last session today. Dr. Patrick Heron is going to be talking about navigating surrogate choices after family violence. Dr. Heron is a clinical ethicist at the Montefiore Einstein Center for Bioethics and a clinical associate professor of family and social medicine at Albert Einstein College of Medicine in the Bronx, New York. He earned his doctorate in clinical bioethics from Loyola University here in Chicago. He currently serves as the chair emeritus of the Ethics and Humanities Educators in Health Professions and Residency Training Affinity Group for ASBH. And he's also on the advisory board for Medical Student Pride Alliance and Executive Planning Committee for BNGAP's annual LGBT Health Workforce Conference. It's a lot of things. And he's a member of the editorial advisory board for the Journal of Hospital Ethics. And he holds an adjunct appointment for the Department of Family Medicine for Georgetown University School of Medicine. Dr. Heron.
So I have the misfortune of being the person between you and the cocktail reception. So my apologies. So I'm going to be speaking about surrogate decision-making in the aftermath of intrafamily violence. If I can advance. Okay. I have no relevant financial disclosures. I will not be talking about off-label or investigational use during this presentation. You're welcome to take photos throughout the talk, but there will be a few slides where I'll have this icon. That's because the family who I'll be discussing, they were gracious enough to grant me permission to talk about their experiences. I have omitted some details, I have changed some details regarding the case I'll be referencing out of respect and their preference that I do so. Okay, thank you. So some of the objectives that I have for this talk and the work I've been doing is exploring the criteria for determining what is an ethically appropriate surrogate situations, especially in situations where there's been an allegation of intrafamily violence, how that information may inform or bias the process for identifying a surrogate. I'm also going to be talking about some of the barriers and challenges that arose for me as a clinical ethics consultant, supporting the family of a patient and the staff that was assigned to that patient's care. So what does it mean to be an ethically appropriate surrogate? Well, we're often asked to draw from several criteria. We have our ethical criteria, we have our legal criteria, which is really what we go to first. We also have our situational criteria. So who's available, who wants to be involved? And I think, when we talk about the legal criteria, there's consistency across most states as to how decisions are made. But there are some states where we have extra challenges. The previous talk referenced unrepresented patients. There are some states where if we're able to find a friend, we would say that person's ethically appropriate, but the state doesn't allow for a friend sometimes to serve in that role. So we have a lot of barriers to our own process. So let's talk about an ethics consult. In this one, I get the call over the weekend from our critical care attending. We have a young adult male presenting with right side facial gunshot wound. He's currently intubated, he's sedated. At the time of the consult, he's been admitted to the ICU. He's described as medically stable, but he's going to require further non-emergent surgical interventions, and he's unable to provide consent. I get a little bit more context as I start talking to the staff. The patient is in the custody of law enforcement, so at that hospital I was working at, he's considered a forensic patient, which has its own set of protocols that we have to follow. There's a police officer who's assigned 24/7 to our ICU unit. So there's already the presence of someone that the care is going to be different because of this individual who's there. The patient's also handcuffed. Even though he's sedated, even though he's intubated, the visual symbolization of him being handcuffed is a constant reminder to anyone walking the room that he's not just a patient, he's a different kind of patient. He's pending arraignment for criminal homicide of his sibling, And I should say, for the alleged criminal homicide at this time, we didn't know all the facts, and the alleged attempted homicide of his mother. The medical team that I'm working with, they're told by the ED, so there's a lot of handoff of information. So some of it is factual, other is hearsay, others is interpretation. The event occurred in the home. His sibling, who was on his way to the hospital when he died in the ambulance. His mother's also a patient at our hospital. She's currently in surgery. And it was initially assumed, but not confirmed, that this was a self-inflicted gunshot wound. But my first conversation with law enforcement, they were investigating because, well, we don't know if it was self-inflicted. And we're trying to get information from other family members, people in the neighborhood, people who aren't talking to us. There is a question that maybe someone in the house actually shot him. And per our hospital protocol, both patients, mother and son, are listed as non-published. So there is another barrier to communication with those who are most interested, most invested in this person's care. So what are some of the initial questions that I'm grappling with as a consultant? Who should be allowed to make decisions on his behalf? I'm immediately hearing concerns from the staff who are voicing, well, isn't it a conflict of interest to have any member of his family be surrogates because of what he's done to his brother, what he's done to his mother? The patient's not able to participate in any kind of medical decision-making or even indicate preferences or values or communicate. And very soon after the initial consult, people start asking, well, what if the mother wants to know what's going on? I mean, it is her son, right? We should be telling her that. Isn't she next of kin? So there's a lot of confusion. There's a lot of questions. As a clinical ethics consultant, I was very fortunate to have really good colleagues to call on. And they were always there to support me and back me up, which I think is a real privilege and not many people have, because often we're doing ethics consults kind of on our own. So there's a lot of ethical dilemmas. There's a lot of moral distraction. There's a lot of things that are keeping me very tense throughout this whole process. So what are some of the barriers and challenges? First was the extensive, I previously used some expletives, exhaustive negotiation with 2 different law enforcement agencies to obtain their permission to communicate with a family member to ascertain if they would be willing to serve as a surrogate decision maker. This was part of our protocol. We had to go through them. And part of that challenge was also explaining, or my mistake, first assuming the language that I'm using, that they understand what we're talking about. I actually had to go through a painful description to say, no, I'm not asking to bring the entire family to the bedside to talk about what's going on. We can do things by phone. We can do things by Zoom. Once I explained that, like, oh, well, that's different. Once we were able to get a family member approved by law enforcement, that was the patient's grandfather, I then had to think about what is going on for this individual, the conversations that I'm having with them. One of their grandchildren has died. Another is critically wounded in the hospital. His daughter is also critically wounded in the hospital. He's trying to process what happened. No one seems to know the why. They know the what. So thinking about how I have these conversations and how I explore with him what he thinks his grandson would want when he's focused on so many other questions. I'm also having to defend, before we've even identified him as an appropriate surrogate, the fact that I should be talking to him about being a surrogate, because many individuals say he's not in the right state of mind to be making these decisions. These were, I'm paraphrasing, but this is the sentiment from many of the very well-intentioned colleagues that I was working with. So exploring with him how he would make decisions was very challenging for me because I was trying to be sensitive, but I also had a responsibility to the patient to find someone. I'm also trying to address the concerns of the staff because they're trying to attend to a patient. It's an ICU. These are all complicated cases. And there's a lot of moral distress because what I'm beginning to see is how people are viewing this individual and the acts that he's been accused of doing. And it's not a surprise to, I think, most people in this audience that in addition to the medical concerns, some of the ways that we're thinking about this, processing this, there's questions about, is this bias? Would we treat this patient differently if he looked different? Questions of classism. Also, we deal with a lot of patients who come in as victims of violence. So there's a lot of isms that we're sorting through. We did communicate to the staff that, yes, the grandfather is an ethically appropriate surrogate. He meets the legal criteria, and we're going to support him in this role to the best of our ability. One of the organizational ethics challenges that I encountered was, for reasons I still can't explain, this patient was moved between units several different times, and every time he went to a new unit, I had to revisit with the staff who is making decisions, why it's appropriate for them to make decisions, and address their concerns about, is he able to make decisions appropriately given what he has done, which was also quite exhausting. And I understand that these questions were coming from a good place, but it often felt as if we're not centering the patient's needs. We're focusing on a lot of other things that are, I would consider, moral distractions. And for me personally, because I was the one staff member that had that continuity with this family, I began to question my objectivity in my role as a clinical ethicist and my closeness to the family, and in that, am I over-identifying with them and what they were experiencing, which is, again, one of the things I was very fortunate to have, a wonderfully supportive staff colleagues who often said, like, no, if you feel like you're making recommendations that really aren't aligned, run them by us. And that was a gift to me to have. So what happened after I eventually had to sign out on the case? There were details that emerged regarding this individual. There was suspicion that he had taken recreational substances that caused a psychotic break, because nothing in his behavior previously revealed any type of violence. And this was sort of a shock to the family. And one of the reasons why they were all steadfast in support of him is that they know him as an individual. He's never had harsh words with any member of his family. And then suddenly this horrific event happened. Given the complexity of his medical needs going forward, the district attorney decided to drop homicide charges. There was a plea negotiation for manslaughter. He was eventually released into the custody and care of his family. But even after the legal questions had been answered, I often thought a lot about how the family is processing with this grief of what happened and moving forward. I was able to keep in touch with the family a brief time later to get a few updates, and part of that process was asking them, this case was really challenging, and I'm thinking a lot about it, and would it be okay if I talked about this with other colleagues? And the family was grateful because they experienced a lot of those isms in their role with the healthcare system, and the grandfather said, if this can help you all take care of people better, then do it, which to me was the greatest vote of confidence I have as a role of a clinical ethicist, that we were able to kind of provide something for the family that was not necessarily what we usually offer, but that humane connection that we are fortunate enough to do when we can do it. So when I started thinking about this more in a scholarly lens, I thought, well, what are best practices? How do we think about these cases where we have patients and there's questions of violence or accusations of violence? And there were other consults that I was getting at the time where there were similar themes coming up. Patients whom had advanced dementia or a cognitive disability in which they were sometimes violent towards their caregivers, and the caregivers were their decision makers, and staff feeling concerned about, well, are these people really appropriate because, look what the patient's doing to them. And the truth is, we don't have policies that address this. We have policies that address how to protect patients when their caregivers are the ones who are perpetrating violence, but not the inverse. So we rely on our typical protocol, like how do we decide who a decision maker is? And if we don't have these policies, if we aren't thinking about it, those isms often get in the way of thinking about, well, maybe these people shouldn't be making decisions because I don't know how I would feel making decisions in this situation. And when we start centering ourselves in these family dynamics, that's a red flag we all need to be very mindful of. I do think if I had to draw on anything that was most helpful, it was my training and experience in trauma-informed care, because those conversations were really crucial to identifying and being able to confidently say to my colleagues, why is it that the grandfather is an appropriate surrogate? And how do we support him in that role going forward? Which is also our responsibility. It's not enough to say, well, we found a surrogate. We have an obligation to them to help them make informed choices. I just want to acknowledge, first and foremost, the family who was gracious enough to allow me to be part of the care, and then to later grant me the permission to talk about their experiences as a way of educating my colleagues and also reflecting on the work that I do. I also want to acknowledge Ava Randall, who's a former intern at the Montefiore Einstein Center for Bioethics, and again, my colleagues at the John J. Lynch Center for Ethics at MedStar Washington Hospital Center. And this is my contact information. So, thank you. So I know we're over time. Do we have time for questions or comments? Okay.
So you have an emergency when he first comes in. So in some ways, was he covered by emergency treatment to stabilize? Yes.
Yeah.
So when you start to bring in the grandfather, what would you have done if he began to advocate for some non-treatment? Mm-hmm. What would you have done?
So that actually was a great way of easing the concerns of my colleagues, because what I shared with them is we often will identify a surrogate. When that surrogate starts asking for things that we think are not medically indicated, not medically appropriate, we should always question the appropriateness of that surrogate, not just in this case, but in any case. So when those things happen, we should pause and think about why are they asking this? And to not end the conversation, but start the conversation with why would he be advocating to not do something?
Yeah, thanks so much for this talk, Patrick. This is about a medical team figuring out who the right surrogate is. I often say that a patient appointing a surrogate is typically a low risk, high reward decision, but sometimes it's not. The kinds of situations you're, I think, alluding to where there might be these really complex dynamics. But I'm wondering how to think about the kinds of situation you presented and the way you're thinking through it when we're thinking about incarcerated patients and surrogate decision making. And the reason I ask, so I do a lot of thinking about incarcerated patients and rights to healthcare. I think surrogate decision making can be a complex spot, because sometimes in clinical ethics we go to the sort of, well, they should have exactly the same, rights and processes as any other patient, including family members being surrogates. And that can be complicated depending on the relationship between those family members and the reasons for the incarceration. Mm-hmm. So I'm just wondering maybe how your analysis might help us think through those kinds of situations.
Yeah, so the challenge with, so there was something I really couldn't get into because of lack of time was, he was never arraigned. So the entire admission in the hospital, he was someone who was in custody, but for which there was no arraignment, which was very problematic because it limited what we could do. And unfortunately, the family was asking me all types of legal questions. And I said, I'm not able to give you legal advice. You really need to find a lawyer. You really need to find a lawyer. He couldn't even get a court-appointed defense attorney because he hadn't been arraigned. So the family was in this horrible position of they didn't have the resources that many families do not. And the one thing that they would get eventually, society, the state was not moving forward in the process. So they were in such a precarious position that, so I think that was something that I really struggled with organizationally. And a lot of people just say, oh, well, he's been arraigned. I'm like, no, he has not. So there was so many problems in how this family was being treated that I think was, very unjust. So I was relieved when eventually the DA did listen to this evidence to say, this doesn't sound like what people thought it was at first. And this was a kindness, not just to the patient, but the family themselves, they were also the victims here of a tragic event. Okay, thank you for your time.
Well, thank you to all of you. Thank you to the presenters. Really outstanding presentations throughout the day, including this afternoon. For those of you who did sign up for the dinner this evening, when you get out to the main lobby, outside the auditorium, look for the signs for the U505. For those of you who did not sign up for the dinner, enjoy your evening in Chicago, and we will reconvene tomorrow morning at 8 a.m. Thank you.